Mr. President, thank you very much for introducing me, and I really appreciate that I'm invited here to support what the society is doing and to answer the questions that I was given. If minimal invasive extracorporeal technology is a contraindication in terminus, and should we embrace this demanding strategy for all cases or diversity or clinical approaches? So in the next minute, I will try to introduce you to this technology and reply to the questions and try to give you some guidelines regarding what's supposed to be this technology, ME-ACT for everyone. So this is an historic picture and indicates how was the extracorporeal circulation or this cardiopulmonary bypass when it was initiated in the clinical practice. 60 years after, as you see, this historic device or historic machine has been evaluated again, and coming from the ECLS circuit, this is the first ME-ACT system that was introduced. So at those stages, all companies and everything was introducing something, as you see, fancy, small, mini, bright, and it was called the mini system, or the beauty of simplicity. And this is the contemporary look of a system which is really complex, and I would say that even though it's complex, to me is the state of the art in perfusion, as I will try to explain why. So coming back to our society, the Minimal Invasive Extracorporeal Technologies International Society, just to let you know that it reached so far to 235 members, and as you see, it has a very good penetration to all surgical members of the team, even though the anesthesiologists are still behind. But regarding the countries, more than 28 countries, now it's 29, has been registered, and as you see, it's quite a nice penetration to Central Europe. What the society tried to overcome all these years is the confusion regarding, first of all, the definition. So throughout the literature and between all of you amongst your clinical practice, there was a quite dispersed terminology regarding this technology, from mini or minimal or miniaturized or minimized or any other word that someone could invent. So the society, in a consensus meeting in Bern, defined that this is not a mini circuit, it's a minimal invasive circuit. So it initiated the term ME-ACT, like minimal invasive extracorporeal, and then if you put these capitals at the end, if you put C, it's circulation, if you put T, it's technology, if you put TIS, it's Technology International Society. So it's very easy to utilize this terminology. And we try to differentiate what is minimal invasive extracorporeal circulation with the conventional system that you saw was introduced from John Gibbon. And we said this is not extracorporeal circulation literally, but it's a cardiopulmonary bypass. So if we consider that ME-ACT is really an extracorporeal circulation, we said that we will name from now on the other one, the conventional system, as a CPB system. So it's conventional CPB versus minimal invasive extracorporeal circulation. Now, it's very easy then to find out why to me or to all the society or to all people who are dealing with this technology, it's not mini anymore. So we overcome this name that was used lately in the literature, because we thought this is, first of all, a commercial name, and second, it's not aligning a lot with what we would imply about this technology. And we put this I, which is invasive, as I said, or international, but you can say, like Steve Jobs, I can be anything you might consider. But definitely this minimal invasive means not just mini that was introduced the first years in the literature like this, but minimal invasive is this system, for example, which we use in my institution, which is a hybrid modular system, and as you see, it's quite complex, but still it's minimal invasive. So when we say ME-ACT contemporary, we mean minimal invasive and not a mini system. What society has also introduced is a classification which really represents the evolution of this technology coming from the ACLS system, as I said, and moved towards the modular systems. So this was the first, simplified system, which we could call mini, because it's literally an ACLS plus a cardioplegia line, cardioplegia circuit, as you see here, Alois Philipp system. Going further, we've included a bubble trap or an air removing device, and we transformed this system to type 2, which we easily could handle air, and we could use it for doing aortic valves. Throughout the years, we had problems with volume management, and we wanted to operate in complex cases, and we said that we need an extra softback reservoir which could manipulate the volume of the patient, because this is a closed system, and literally the cardiovascular system of the patient is the reservoir, but sometimes you need to manipulate it. And so including this softback into the system, we went up to the third type of this technology of MEAC. And then, of course, came the necessity to apply this technology not with indications, but to all cardiac case mix, doing right side cases or mitral complex, redo aortic arches or dissections, emergency cases. Then we needed this extra component. You can see here, I don't have a pointer, so just on the right, you see it's a heart cell reservoir, which is with a short circuit, and you can always transform this. Transform this circuit to an open one as soon as there is any event like a huge blood loss or a massive air entry, and then you say that you have an open system. Regarding all these, and mainly the guidelines or the clinical applications of the system, the technology had published this position paper, which is actually a consensus paper regarding all these definitions and classifications and requirements, and it tried to characterize what will be a MEAC system, because so far there are so many custom-made systems that are modifications from conventional CPB, and we all name them as mini, but the society says if we want to define what is a MEAC, it needs to have these basic components and these additional components that may be included to the circuit to be named as a MEAC system. So if a system is not utilizing these components, could not be considered as MEAC. It can be considered as a modified CPB or modified mini system, but not a MEAC system. So from this slide, you can appreciate that this is not a mini system. It has all these components, and definitely it makes it complex if you include all of them in one system anyway. Going further, what society has introduced is that MEAC represents a strategy and not just a circuit. So this is the reason that a teamwork approach is mandatory to gain the maximum benefit from it. And what I've designed is this cycle definition of the procedure, which says that the circuit is here, the system is all the peripherals included, and the strategy is what the teamwork comes in, when the teamwork comes in, and as I will indicate later on, gives you some landmarks and some algorithms to follow and have the maximum benefit. So let's say minimal invasive extracorporeal technology necessity. Is it there? I mean, do we need it? And let's go with the most, let's say, attractive alternative that is so far, especially for CABG cases, the off-pump use. And as you see here, to a recent publication, this goes down. And it's not more than 10–15% worldwide, the utilization of OPCAB technique. And that's why there are a lot of voices in the literature saying that this is an old technology nowadays. And it's obvious because this is based to all the recent meta-analysis and the big studies, randomized studies that have been published. And as you see here from the biggest study, Ruby, with 2,000 patients, the one-year composite outcome for CABIDs and the mortality in this year is worse when you utilize this off-pump technique. And this was proven not just from randomized trials, but from meta-analysis. As you see here, the graft patency and the mortality is worse when you utilize the OPCAP technique versus the conventional CPB system. But what happens if we compare the MEAC system towards the OPCAP technique? If you see here, it's very comparable to all outcomes, even the hard endpoints like mortality. And that's why this big meta-analysis implies that when you utilize a MEAC system, literally it's like simulating an off-pump technique. That's why we call this system as a minimal invasive extracorporeal circulation. It's like an assist device and not like a cardiopulmonary bypass that we have all used the old days. And if we see this huge network meta-analysis with 23,000 patients, you see that regarding the outcome, all the hard endpoints here and the major adverse events are much better from when using the MEAC system rather than the OPCAP technique, and of course much better than the conventional CPB. But the problem with this paper, even though it indicates this, it says that MEAC represents an attractive compromise between OPCAP and conventional CPB, even though they should appreciate that this is different here statistically. And then we wrote a letter, a reply to them, and no answer was given that according to their data, this is an attractive dominant technique, and it's not a compromise. It's definitely much better to utilize the MEAC. So if we compare now the MEAC system with conventional CPB, the biggest meta-analysis here indicates that there is a mortality benefit and also MACE benefit, major adverse cardiac events benefit regarding this technology. And if you see here, it's quite strong. You could say that this comes from dispersed data in the literature from a lot of randomized controlled trials, as you see, but definitely this is a class 1A guideline. But is it just the clinical indications that gives the power of this technology? No. What I would say is when you are operating on an average young patient with good ejection fraction doing CABG, even if you're operating him off-pump or on-pump, conventional or MEAC, he will be fine. I mean, 50, 60 minutes of cardiopulmonary bypass would make no difference on him. But if you operate on a fragile octogenarian with heart failure, pulmonary hypertension, lots of comorbidities, renal failure, chronic obstructive pulmonary disease, then you have it. Then you will definitely have compromise of his physiology throughout surgery, and then the patient postoperative will have morbidity. And that is when MEAC system really works nicely, as you see here. And what we say is, if you want to apply this technology to high-risk patients, then you need to start with the average, the patient, where of course everything can be applied easily. And what we recently published here is not just the clinical outcome in the hospital that counts. As you see here, throughout their life, the quality of life, what measures a lot, is much better when you utilize the MEAC system rather than the conventional CPB. And going lastly to the cost, to the money, we have proven that when you utilize this technique, since you're reducing a lot, the blood transfusion, the ICU stay, all the morbidity, the major morbidity that might come from the surgery, definitely is cost effective, and this technique is dominant, especially in these countries that we made this analysis. To finalize with what is in clinical practice, in the contemporary clinical practice, very attractive, that is minimal invasive cardiac surgery. As you see here, when you compare the conventional CPB with MEAC regarding ventilation, ICU stay, postoperative delirium, neurocognitive, and blood transfusion, everything comes better when you're using the MEAC system. So it's obvious that it takes two to tango, as we say here, and I believe when you want to name yourself that you're doing minimal invasive cardiac surgery, it's really a contradiction to not to use the minimal invasive extracorporeal circulation, because then you transform the surgery to cosmetic surgery and you are not using the means, the technology that will transform this surgery to minimal invasive surgery. Now, regarding my concept, or the concept that is contemporary in practice when we say all cardiac case mix, it's the modular systems, as I've indicated earlier on, which really work nicely in 100% of the cases. We use now these modular systems the last 3 years with 100% patients from our practice. That means all comers. And we are an academic hospital having emergency cases and all 2-3 times redo cases, and the conversion rate is, as you see, very minimal. So it's feasible. That means that 96% of the cases you don't need this hard shell, the extra component. But if you need it, it's there. So this overcomes all the safety issues, all the concerns, and all the indications that you might set for using it. And when we compared the standard MEAC with the modular, as you see here, we found that even in very good results here, which are replicating with the modular system, it's something that it's a bit better. It's neurocognitive. That means that it's something there that is much better the last years in my institution. And what is there? What is that? It's the strategy that we utilize, and I will say to you later on what is this strategy. So, why all this come to this technology? Many times I have given these 3 slides that I will show you. One is that throughout surgery, when you are on pump and you are using the MEAC system, to all pump rates, as you see here, the mean arterial pressure is much better preserved when you use the closed system, and this is with less norepinephrine or less vasoconstriction. And this can be translated in the periphery as well. And as you see here, the microcirculatory hypoperfusion that comes from the conventional CPB is more when you operate this system rather than when you are using the MEAC, and also the recovery of the microvascular organ perfusion is much better, as you see in this paper. So there is a rationale behind this technology. Now, let's say that you are convinced that this is nice technology and you should apply it. What are the requirements then to do it? First of all, you all need to be skillful regarding the perfusion, but you don't need just your skills. As you see here, you need to have a meticulous surgeon, a bright anesthesiologist, and stepwise training with a strategy that will render all of you a real teamwork. So this is really something that needs to be in a decisive team, otherwise you cannot do it. For this reason, we have some initiatives like trainings that we're doing in our institution, and there are lots of trainings throughout at least Europe. And what society has also introduced is multidisciplinary training programs, and as you see here, we had also 2 congresses so far, and the next one is in 2 years in Bern, 2018. And regarding the learning curve, we are about to publish, it's in press in Artificial Organs, I think this month will be published. We found out from our cases that you need 50 cases with utilizing this system on CABG patients to, let's say, obtain the optimal results as a team. So 50 cases in CABG would be enough to go further and go, for example, for aortic valves, and then it's easy to convert to any cardiac case mix. Of course, you need to be taught. So you need teaching regarding tips, tricks, and pitfalls. And what I said is you need a strategy. So we initiated a strategy the last 2 years in my institution, which is called a physiologic cardiac surgery. And it's a perioperative strategy that we are about to publish. And what we are doing is we have a goal-directed cardiac surgery, not perfusion, not just perfusion, not just the metabolic issues that the perfusion is, which is P, is measuring from the spectrum device here. But as you see, this is the anesthesiologist, this is me, the surgeon. So all three of us are in one square meter. And we have a lot of parameters that we are using as goals. So that's why I said this is a goal-directed cardiac surgery. And it's a real-time monitoring and adjustment rather than incremental correction. And it needs, of course, the MEX system and the teamwork. And this is basically the algorithm that we use. We have pre-op and pre-pump and post-pump, the anesthesiologist that is measuring SVO2, CCO, and throughout surgery, DO2 and DO2 to VCO2 index. And we have spectroscopy, infrared spectroscopy from brain, NIRS here throughout the surgery. And this is our inline data acquisition. And incrementally, we challenge this technique to lactate and urea output, and then we have action. So mainly, this is a strategy. This is the algorithm that we use it so as to obtain physiologic results. And this really works. And if you see the curves that represent this strategy here with the NIRS, you see this is when we started the conventional CPB that really crashes the patient when he comes on pump. But in off pump also, there are lots of fluctuations to the brain. And we utilize the brain as an index organ, not just a target organ, because then we say this is perfusion. And so perfusion of the brain is perfusion of all peripheral organs. And as you see here, there are lots of fluctuations. But when you obtain curves from our physiologic strategy on MEX system, as you see here, it's literally flat line. And this makes the difference because the patient is intact. And what we say is that physiologic perfusion is mandatory nowadays. So, Mr. Chairman, to conclude, what we published from the position paper is the recommendation and the level of evidence utilizing the contemporary literature regarding this technology. And as you see here, class 1A, that is very strong, is that MEX system reduce hemodilution and the need for red blood cell transfusion, and also reduce atrial fibrillation, preserve renal function, and improve myocardial protection. So this is a class 1A recommendation, and what I say is we should urge to put these in the guidelines, especially when you are when you are operating on CABG patient. Is this enough? I mean, is this hardware enough or the circuit enough to obtain the good results? No, you need a MEX strategy. If you have this, what we would need to penetrate or to the clinical practice more is a multi-center prospective randomized study which will prove what we all do at our institutions. So we are very close to launch this study, which is COMICS trial on behalf of MEX. So far, we are 20 centers recruited who will start their cases early June next year. We have applied for an Horizon 2020 grant, and this will be one of the biggest trials in cardiac surgery. Nearly 4,000 patients between two groups, two cohorts, conventional CPB and the MEX system. It's invited to all of you. Whoever wants to be recruited, just join us online to www.meactis.org. So the evolution to the systems throughout the years is that conventional system went to off-pump strategy and then went to MEACT, and that goes in parallel with evolution in perfusion, who came from empirical, adequate, maximal, optimal, and to me, physiologic is the ultimate goal. And since more physiologic perfusion should become the standard technique, as we say here to this nice editorial that was invited, I would conclude with this slide, replying to the question I was given. Is MEACT a mini system? No, it's not a mini system. It's not a simplified setup, but it's a minimal invasive system which is more complex and demanding, yet more physiologic and beneficial from CPB. So I think this is the way forward, and I believe that perfusion needs to be adjusted in this technology that is evolving, and it's very nice and it should prevail. Thank you very much.